Welcome to today's customized deep dive. Every year, millions of women are handed these glossy 5-minute mommy makeover brochures.
Oh, yeah, the ones promising to basically painlessly erase all the physical discomforts of childbirth,
hmm
usually with like a quick laser treatment.
Right, exactly. But what those brochures conveniently leave out is the massive FDA safety warning sitting right next to them in the medical literature. So today, we are cutting through this multi-million-dollar marketing machine.
We really have to because the contrast in the stack of sources you shared with us today is just staggering.
It really is.
I mean, you have aesthetic clinics speaking the language of a high-end day spa, and then you have clinical guidelines from NICE and the FDA speaking the language of severe anatomical risk.
And you, our listener, are caught right in the middle of this. You're reading these brochures and, you want relief from the physical changes or discomfort you're experiencing after childbirth.
But you also know you might want another baby in a couple of years.
Exactly. So you're stuck asking yourself this really specific question. Do I suffer in silence for another 2 years, or do I risk ruining a really costly procedure by getting pregnant again?
It's a tough spot to be in.
It is. So, okay, let's unpack this. We are going to use your sources to build a clear, medically backed timeline for what you should do right now, what you should approach with heavy skepticism, and what you absolutely must delay.
And that timeline completely changes depending on the specific anatomy we are dealing with. We basically have to separate the musculoskeletal foundation from the mucosal tissue.
Right, and separate the internal repairs from the external ones.
Exactly.
So let's start with the foundation. Let's bypass the abstract marketing ideas and look at the physical reality of a vaginal delivery, because we aren't just talking about tissue getting a little bit stretched out.
Not at all. What's fascinating here is that this is an event of maximum physiological load. It is a profound structural event.
I was looking at the anatomical breakdown in the sources, and it's intense.
It really is.
Yeah.
During delivery, the levator ani muscle, which is the primary muscular sling of the pelvic floor, undergoes extreme distension.
Like stretching to its absolute limit.
Right. And sometimes there is macroscopic tearing, like where the muscle fibers actually rip away from the pubic bone. And along with that, the visceral pelvic fascia can be permanently stretched or torn.
Which is basically the biological suspension bridge holding up your pelvic organs.
Exactly. But the part of the research that is really critical to understand involves the nerve damage.
Yes, the pudendal nerve. That part made me genuinely pause, because it doesn't just get irritated, right? It gets physically stretched.
Stretched and compressed. I mean, imagine a thick electrical cable being pinned against a solid brick wall by a really heavy weight.
Oh, wow.
Yeah, as the baby's head descends, it compresses that pudendal nerve against the pelvic bones while simultaneously stretching it up to 20% of its original length.
And nerves definitely do not handle tension well.
They don't. That stretching damages the myelin sheath, the protective coating of the nerve. And that severely disrupts the electrical signals traveling from your brain to your pelvic floor muscles.
Which perfectly explains why stress urinary incontinence is so common, leaking when you cough or sneeze or laugh.
Right, because if your brain is sending a signal to that muscular sling to contract and absorb the pressure of a sneeze, but the nerve is damaged.
The signal just never arrives.
Exactly. The muscle stays relaxed, the bladder gets pushed down by the abdominal pressure, and you leak.
And that biological reality leads us to the very first answer to your timeline question. Because of this trauma, pelvic floor muscle training, or PFMT, is the one intervention every single medical source agrees you must not wait on.
Do not wait. Whether you're having another baby in 10 months or 10 years, you start this rehabilitation usually around 4 to 6 weeks postpartum.
But wait, I have to throw a flag on the play here. When people hear pelvic floor training, they usually just think of, doing regular Kegel exercises while stopped at a red light.
Right, the stoplight Kegels.
Yeah, and I think a lot of patients try that, see absolutely zero improvement, and just assume their body is broken.
Well, they assume it fails because they're trying to fire a muscle with a damaged electrical connection. If that pudendal nerve is compromised, you can sit at a red light and squeeze all you want, but you're probably just clenching your glutes or your abs.
The pelvic floor itself isn't actually engaging.
Exactly. This is why the clinical definition of PFMT in your sources is so rigorous. It's an active, targeted physical therapy regimen that often requires biofeedback.
Unpack biofeedback for me. I know it involves sensors, but how does it actually fix that nerve damage?
Well, it doesn't bypass the damage. It helps repair the connection through neuroplasticity. A physical therapist places sensors on or inside the pelvic floor that connect to a monitor.
So you can actually see what's happening.
Yes, when you try to contract the muscle, you see a visual representation on the screen. Maybe it's a graph spiking or a light turning green.
Oh, that's really clever. So even if the muscle movement is so microscopic, you can't feel it, you can see it.
Right. Your brain registers that visual success and starts to rebuild and strengthen that specific damaged neural pathway.
It's essentially retraining your brain to find the muscle again.
Exactly, and it requires real dedication. The literature details protocols of like 8 sustained contractions 3 times a day for a minimum of 3 months.
Wow. Okay, so that is physical rehabilitation in the truest sense.
It is. So for your timeline, do not delay this. Build the foundation back up immediately.
Okay, so physical therapy rebuilds the muscle and the nerve connection. But what happens when the issue is the tissue itself?
Ah, right, the mucosal tissue.
Yeah, because the clinical guidelines highlight that a lot of women experience severe vaginal dryness, tissue laxity, and pain during intimacy, symptoms that actually mimic menopause.
Which seems incredibly counterintuitive for someone who just had a baby.
It really does. Why would a postpartum body act menopausal?
It makes sense when you look at the endocrinology. Hormonally, a postpartum patient, especially if she is breastfeeding, is in a state very similar to menopause.
Because of the prolactin.
Yes, the pituitary gland produces high levels of prolactin to stimulate milk production, and prolactin actively suppresses the ovaries.
Which causes a dramatic drop in estrogen levels.
Exactly. And estrogen is what keeps the vaginal tissue plump and elastic. Without a steady supply of it, the vaginal mucosa changes at a cellular level.
And it gets really thin, right?
Very thin. The medical term is friable, meaning it tears easily, and it loses its ability to produce natural lubrication. So it is a genuine physiological deficit, not just a cosmetic issue.
Which brings us to the messy middle ground of your sources. When physical therapy isn't enough to fix this tissue dysfunction, patients start looking for solutions.
And that's exactly when the aesthetic industry swoops in.
Right, with energy-based devices, specifically CO2 and erbium YIG lasers.
And this is where the friction between your sources hits an absolute boiling point.
Oh, definitely. I was reading the mechanism of action in the clinical guidelines, and I couldn't really wrap my head around it. They are essentially using lasers to create controlled thermal injuries, microscopic burns inside the vaginal canal.
To force the body to heal itself, yes.
That sounds incredibly aggressive.
Well, the basic science relies on the body's wound healing cascade. The laser energy targets the water molecules in the vaginal tissue. It basically vaporizes microscopic columns of tissue.
Just vaporizes it.
Yeah, which creates immediate swelling. And this trauma signals the fibroblasts, the cells responsible for your structural framework, to rush to the area and produce brand new collagen.
Okay, neocollagenesis. So the newly generated collagen is supposed to thicken the tissue and restore elasticity.
That's the theory, yes.
So returning to the listener's core question here, if a patient gets this laser treatment to build up all this new thick collagen, is it safe to just get pregnant and push a baby through that same tissue a year later?
Does a subsequent birth ruin the laser work? From a strictly mechanical standpoint, the limited data suggests it doesn't cause harm to the delivery process. Your sources include a small study by Gaspar and colleagues observing 37 patients who had erbium YA laser treatments.
Okay, 37 patients. Pretty small.
Very small. But the study found the laser treatment had no negative impact on their subsequent vaginal deliveries. So because of small studies like this, clinics feel empowered to market lasers as a perfectly safe maintenance tool to use between pregnancies.
Here's where it gets really interesting, though. If dermatologists use these exact same collagen-stimulating lasers on faces every single day, and it's totally standard, why is the FDA coming down so aggressively on vaginal lasers?
That's a great question.
Because the FDA's safety communication in your stack is not mincing words.
No, they are not. The FDA is looking at the MIUD database, that's the Manufacturer and User Facility Device Experience database, where adverse events are tracked.
And the reports are bad.
The reports they are seeing regarding vaginal lasers are terrifying. We are talking about severe, full-thickness burns, permanent scarring, and chronic debilitating pain.
Good Lord. Because the tissue inside the vagina is just fundamentally different from the skin on your face.
Vastly different. The epidermis on your face is designed to be exposed to the elements. It has a tough outer layer of dead skin cells. But the vaginal mucosa is an incredibly delicate internal environment.
Especially postpartum.
Exactly. When you apply aggressive thermal energy to an area that is already thinned out and fragile due to that postpartum drop in estrogen we just talked about, the risk of a catastrophic healing response skyrockets.
Right, because the tissue is already compromised. One of the complications listed in the NICE's guidelines was the formation of a transverse vaginal septum. I actually had to look that up.
It's severe.
We are talking about a literal wall of scar tissue forming and blocking the vaginal canal.
Yeah, there's a specific case report of a 48-year-old woman treated for incontinence with a laser. The thermal injury caused the raw tissues to literally fuse together as they healed.
Oh my.
It left her with a vaginal length of only 2 to 3 centimeters. She required major reconstructive surgery just to undo the damage caused by the laser.
That is the ultimate red flag.
It really is.
So, translating this back to the listener's timeline dilemma, an aesthetic clinic will hand you a glossy brochure saying a laser is a quick, safe fix while you wait to have your next baby.
But the FDA and major medical bodies are telling you the safety profile is completely unproven.
Right. The long-term randomized trials do not exist, and the worst-case scenarios involve permanent disfigurement.
So the medical consensus here is to proceed with extreme caution. The risk-to-benefit ratio for energy-based devices in postpartum patients is highly controversial.
So what should they do instead?
If you are between pregnancies, leaning into physical therapy, or discussing localized prescription estrogen therapy with your doctor is a far more established, safer route.
Okay, so if lasers are a regulatory minefield and physical therapy simply cannot physically sew a torn muscle back onto the bone, what happens when a patient is still in significant pain?
They inevitably turn to surgery.
Right. And this is where the question of, should I wait if I want another baby, gets two completely opposite answers.
Because the dividing line is internal versus external anatomy.
Let's start internal. Vaginoplasty.
Okay, so a vaginoplasty addresses the deep structural failure of the pelvic floor. If the muscles have separated or torn beyond what physical therapy can fix, a surgeon goes in, removes the excess stretched mucosal lining, and uses deep, absorbable sutures.
To basically physically pull the separated muscles back together.
Exactly. They tighten the entire internal canal.
I keep picturing this like beautifully renovating a narrow hallway. You put down new floorboards, you patch the drywall, you paint it.
Okay, I like this analogy.
Well, if you are planning to have another baby, getting a vaginoplasty is like doing all that delicate hallway renovation right before moving a giant heavy sofa through it.
It's going to get destroyed.
Right. The sofa is going to scrape the walls, rip up the new floorboards, and the hallway is going to get completely wrecked all over again.
The physics of childbirth make that an incredibly apt comparison. A subsequent vaginal delivery will subject those surgically repaired muscles to the exact same maximum physiological load that tore them in the first place.
So the stitches just fail.
The deep sutures will fail, the muscle fibers will stretch or tear again, and you will completely undo the surgical repair. Every single medical source in your stack is unanimous on this.
If you want more children, you must delay a vaginoplasty.
You must delay it until you are absolutely certain your family is complete. You do not want to endure the cost, the anesthesia, and a brutal 6-week physical recovery only to have it reversed.
Okay, so internal hallway renovations wait until the heavy lifting is done. But the rules flip when we move to external surgery. Labiaplasty.
Right. Labiaplasty is the surgical reduction or reshaping of the labia minora or majora, the external lips of the vulva. The key anatomical difference here is that the labia do not play a structural, load-bearing role during a vaginal delivery.
They are just external soft tissue.
Exactly.
So sticking with the house metaphor, a labiaplasty is like fixing the porch light.
I see where you're going with this.
Yeah, the giant sofa you're moving into the house isn't going to bump into the porch light.
It's true. The delivery mechanism bypasses the labia surgical site entirely. A surgeon typically performs what's called a wedge resection, where they remove a V-shaped wedge of excess tissue that might be causing chafing or pain.
And then they just stitch the natural edges back together.
Right. And because that physical tissue is permanently excised and thrown away, it does not magically regrow.
Which means the timeline verdict here is actually incredibly freeing. You do not need to wait until your family is complete to get a labiaplasty.
You really do not. Now, the literature does note a tiny caveat. During the 3rd trimester of a future pregnancy, massive surges in blood volume and hormones can cause some temporary swelling in the labia.
But the fundamental surgical reduction is permanent.
Yes. A future birth will not undo the surgeon's work.
That completely reframes the decision. I mean, a listener doesn't have to suffer with chronic chafing, irritation, or pain in her clothing for 5 years just because she might want another baby down the road.
Exactly. She can fix that specific issue now. However, and this is important, There is a universal short-term waiting rule that applies to every single postpartum surgery.
Right, whether it is external, internal, cosmetic, or structural.
Yes. Even if you aren't planning another baby for 5 years, no reputable surgeon will operate on you until you are at least 6 to 12 months postpartum.
Let's explore the why behind that. Is it just about letting the microscopic swelling go down?
Well, the swelling is a factor, but the primary reason goes back to estrogen.
Oh, the hormonal state again?
Exactly. If a patient is 3 months postpartum and breastfeeding, her tissue is entirely deprived of estrogen. It is thin, fragile, and lacks proper blood supply.
So if a surgeon tries to stitch that,
The tissue can literally crumble. It just doesn't hold a stitch well. It is highly prone to infection, and the scarring can be severe and really asymmetrical.
you're basically operating on a moving target.
Exactly. You must wait for your hormones to completely stabilize, for the prolactin levels to drop, for your menstrual cycle to regulate, and for estrogen to repopulate the tissue.
And only then does the tissue have the strength and elasticity to heal properly from a scalpel.
Right. You wait 6 to 12 months so your body can find its new permanent baseline.
Okay, let's synthesize all of this into a concrete roadmap for you, the listener. You hand us a massive stack of contradictory sources, and we've basically distilled it into a clear, phased approach based on your specific reproductive timeline.
Phase 1 is immediate and non-negotiable. Begin your pelvic floor muscle training as soon as you are cleared, which is typically at 6 weeks.
And do not assume you are doing it right on your own at a stoplight.
Please don't. Find a pelvic floor physical therapist. Utilize biofeedback to overcome the pudendal nerve damage and put in the daily work to rebuild that neural pathway. This is essential regardless of future pregnancies.
Okay, phase 2 requires extreme caution. When physical therapy isn't enough, you will be heavily targeted by aesthetic clinics selling laser treatments.
But remember, while they might not mechanically interfere with a future birth, the FDA warns that inserting controlled thermal burns into fragile estrogen-deprived vaginal tissue carries severe risks.
Including permanent scarring. So explore local estrogen therapies with your doctor before jumping to lasers.
And phase 3 is surgical timing. If you require deep structural repair, a vaginoplasty, you must delay that surgery until your family is completely finished.
Otherwise, a subsequent birth will just destroy the repair.
Right. However, if you are seeking external relief, a labiaplasty, you can safely pursue that procedure between pregnancies.
Provided you wait the mandatory 6 to 12 months postpartum for your hormones to stabilize and your tissue to regain its strength.
Exactly.
So you don't have to choose between the aesthetic clinic's glossy promises and the regulatory body's terrifying warnings. By understanding the biology of your own body, you can navigate both.
Absolutely.
But, as we look through all these sources, a broader theme kept jumping out at me, and I want to leave you with this final thought. Look at the language used by both the medical and aesthetic industries when discussing postpartum bodies.
Oh, it's very telling.
It is. The terminology is almost exclusively focused on rejuvenation, on bouncing back to a pre-pregnancy state, on fixing what is loose or damaged.
It is entirely built on a narrative of deficit. The baseline assumption is that the postpartum body is ruined.
Yeah, it frames the female body as a damaged artifact that desperately needs to be rewound to the past. But why do we accept that premise? You just adapted to maximum physiological load to grow and deliver a human being.
It's an incredible feat.
Your body didn't break, it transformed. Why is the billion-dollar goal always to erase the evidence of that transformation, rather than finding ways to support, strengthen, and optimize a completely new, evolved baseline?
That's a great point. When we treat the body as something that needs to be reversed rather than a living dynamic system that evolves, we pathologize a natural biological process. It really limits how we approach healing.
So as you navigate this timeline and figure out what treatments are right for you, remember that you aren't trying to force your body to pretend the last 9 months didn't happen. You are just reinforcing the foundation, adapting to the changes, and ensuring that your body is strong and comfortable for whatever stage comes next.